We now move on to one of the highly anticipated parts of the program, a panel discussion, where things usually get a little more interesting. The topic for this session is ERAS in oncosurgery, a concept that has transformed perioperative care and has made us all think a little outside the box, branching away from the old ways to new revolutionary concepts. We have a fantastic panel with us today. We have Dr. Rajat Raghunath, professor from the Department of Colorectal Surgery, CMC Vellore, Dr. Sohan Solanki, professor of Anaesthesia, Tata Memorial Center, Mumbai, Dr. Nirmal, professor, Department of Urology, CMC Vellore, and Dr. Aparna Williams, professor, Department of Anaesthesia, CMC Vellore. And to keep this discussion lively, focused and on time, we have our moderators, Dr. Punita, head of Department of Anaesthesia, Pain and Palliative Care, Adyar Cancer Institute, Chennai, and Dr. Janni, assistant professor, Department of Anaesthesia, CMC Vellore. I invite all our panelists and moderators to kindly come forward and take their seats.
Good morning, one and all. I welcome you all for a panel discussion on ERAS in oncosurgery. We have our 4 esteemed panelists here. So, ERAS, Enhanced Recovery After Surgery, is an evidence-based, multimodal, multidisciplinary, integrated program. But what makes it different when it comes to an oncosurgery? We have our own hurdles, frailty, chemoradiation, a complex surgery. Why do we need this discussion? To explore practical implementation of the ERAS, what are the real-world barriers that we have, and we do have our areas of disagreement as well. So these are our core elements of ERAS, which includes preoperative, intraoperative, and a lot of post-operative elements as well. The specific challenges when it comes to oncosurgery includes patients presenting with an advanced malignancy, malnutrition as discussed, immunosuppression, surgeries involving major resections, and of course safety concerns. So there comes the question, where margins and morbidity deeply matter, can we truly fast-track recovery without compromising outcomes? So I now hand over to Dr. Punita.
Thank you, Dr. Janani. Congratulations to SOAPC Vellore team, and thank you for inviting me. So let us go into the discussion. How feasible is ERAS here in our Indian setup? Let me ask the esteemed panelists, like whether all of them are following ERAS, like maybe Dr. Sohan, let us start with you, for all areas.
Yeah, so if I talk about my hospital, so we started this ERAS proper program in 2014 when we, in our one of our hospital conference, we invited Dr. Henrik Kellick, who was the surgeon who started the ERAS in the world. So from 2014 since last 12 years, we have a structured ERAS program. So we are following in almost every element and almost every actually that we had some organ-specific surgeries like GI, thoracic, gynec, head, neck. In every area, some of the like in this bone and soft tissue, we were not having a formal, but we did this study and there also we started a formal things. So it is feasible if you do in a proper way. It is feasible in your hospital if you do.
Okay. Can I ask Dr. Nirmal?
Yeah, I'm Nirmal. I'm from urology. So ERAS in a setup like CMC is very feasible. Okay. There's no doubt about it. Okay. But surgeons, compliance with ERAS has been an issue. Definitely has been an issue. We started ERAS in bits and pieces in urology. So 2007 was the first paper by Tabibi in uro-oncology, yes, where he compared, bowel prep versus no bowel prep. Yeah. So that was read in our journal club, and our HOUs were, progressive enough or enlightened enough to actually adopt that, and we stopped that miserable peg leg which we used to give our patients, So that's when things started. But a structured program got delayed, and after my training at MSK, when I came back in 2017 or something, we actually established a structured program, and we almost follow all the elements of the ERAS program.
Okay, yeah. Can I ask Dr. Rajat?
I'm Rajat, I'm colorectal surgery. Colorectal surgery has been one of the front runners for ERAS. We have gone through cycles of evolution of the evidence for ERAS and slight changes that have come through it. So definitely we were one of the front runners. I will not say it started off everything at one go, because there is some slight, takes time to change surgical dogma, and everywhere, there's certain things that are fixed in our minds, and for that to change. But definitely over years, and this has been linked now for the last even almost 19 years, we've been started changing. And over the years, we have almost completely evolved into a unit that does ERAS for almost every patient. Sensibly, we do it ERAS. We are don't go gung-ho about it, but definitely ERAS for every patient that we do.
Yeah, Dr. Aparna?
So as my surgeons have mentioned, we are following as much as possible, and as anesthetists, definitely we have a major role to play, and where feasible, we are incorporating the components that are
So you are
acceptable to us.
personalizing it to individual patients. Okay. So are ERAS pathways directly translatable to oncosurgeries or require thoughtful modification? I think most of you have answered it. So do short-term benefits translate to long-term outcomes? This question I would like to ask the surgeons. So how is the long-term outcome for you patients in
yeah, so unfortunately,
radical
urology, we
cystectomy?
don't have too much level 1 evidence. Most of it is extrapolated from colorectal studies and all. But to give you a very broad answer, short-term benefits are definitely there, but whether they translate into long-term oncological outcome, that is cancer-specific survival, overall survival,
Yes.
there's no evidence for that, and I'm not sure. Indirectly, you can say, yeah, ERAS reduces complications, so your complications are less, patient's recovery is faster, functional recovery is faster, so maybe he can go on to chemotherapy much faster, and that can translate into outcomes. But I think more important, the factors which affect cancer-specific mortality and overall survival, etc., is your pre-op albumin levels, HB levels, your comorbidity index, your comorbidities, and sarcopenia. Those are the things which, if modified pre-op, can definitely have a bearing on the outcomes, the cancer-specific outcomes. But ERAS specifically, short-term outcomes, which you can assume that they translate into this thing, but we don't have strong evidence for it.
What about in colorectal?
So colorectal cancer, the first philosophical answer, yes, as Dr. Nirmal said, patients get better. Initially, about 15 years ago, our data showed that only about 40% of our patients went for neoadjuvant chemo, because by the time they got discharged out of the hospital, they're already delayed discharge. So they were not going up to their adjuvant chemotherapy. But that has increased now, and so definitely that way, long-term outcomes. But actually now there's more evidence to say that even ERAS in a short term has, at least in colorectal, has an oncological benefit. Decrease insulin resistance, trigger points for blood transfusions, all that has been shown that as just on increasing survival only on cancer. So definitely short-term benefits does translate to long-term, especially in colorectal cancer.
So may I ask you one thing? Does it decrease the readmission rates or is there an equivocal evidence in the readmission rate? Because most of the literature when I was going through, it has no effect over the readmission rate. So what in your experience, do you see any translation between ERAS and readmission rate?
So ma'am, I want to say the issue with one against an ERAS is ERAS had come up as a Western concept and has come to India. One of the things that I thought will come down was one of the things that we have is like a colorectal cancer, low anterior resection. The patient, we would like to discharge him by day 3. He's eating, he's passed some flatus, he's not passed stools. But that means his complication happens when he's outside in the lodge. For us, that's quite a worrying thing because he's not under our eye. Most Western countries, I've worked in the UK, they have nurses calling them up every day, following it up, which in an Indian setup still has not been translated that vigorously where there's such close follow-up. Basically, our patient gets discharged, comes to OPD, and so I don't think readmission rates should be taken as a measure of quality of ERAS at this moment in a country like ours. Yeah, because it will take some more time for the evidence to evolve for us to say that specifically. But definitely, ERAS definitely, as we all know, has decreased the length of stay. Readmission rates, I'm not so sure yet.
Okay.
Yeah, very interesting. I just want to build on what Rajat said. So when we actually did a study in our unit on ERAS and sent the publication to Indian Journal of Urology, which is the most coveted journal in India, the reply from the editor-in-chief was length of stay is irrelevant to India, because he was using the same logic which Rajat used.
Okay.
Because you'd like to keep the patient back till he actually crosses the threshold where you expect a complication to happen, which is around day 5 to day 7. That's when the anastomotic leak happens. But having said that, we have been successfully able to overcome that inhibition, and our lengths of stay have decreased from 11 to 7. So we're actually discharging patients before that so-called threshold.
Okay.
So our readmission rates, though literature says is 30%, in CMC it's less than 10%.
So I think we have to let the world know about it, because our readmission rates are very less. Okay. So high and low adherence, how flexible can we be, ma'am? So what do you suggest, or how do you convince your surgeon or the patient to, take the time to prehabilitate, or?
Like the surgeons have also discussed, our population is not equivalent to the Western population, right? So we are talking about patients who are not very well educated. They don't understand the implications, So right from starting from counseling, how you talk to the patients, and whether they do understand how the extent of the surgery and the post-op recovery. Our problems start from there itself. Added to that is the financial burden, because it's a cancer surgery. A patient's going to be in the hospital for a long time, might come in back with complications as well, and the chemotherapy or radiotherapy if feasible. So we do have issues there. It's not a funded program like in the UK or the US, So yeah, definitely, patient paying from their own pockets is a big hurdle.
Yeah. Dr. Sohan?
So definitely, like a high adherence is better. So like in any ERAS program, anywhere in the world, you're more than 70% or 75% compliance to the pathways is having, this is a good evidence that is have a better outcome. But again, the thing is that there are hundreds of the elements. And we don't know which element is going to. Some people are taking some 30 elements, some people are taking 20 elements, some people are taking 10 elements. If I'm taking only 10 elements, I may be adherent to the 100% of the pathways. So there is a very vague data available in the world, and so that is why the one of the major drawback the ERAS is how many elements to take. Yeah. There are 100 elements. We don't know how this thing.
I think the compliance, what they say is ERAS is dose dependent.
Okay.
So the higher the compliance, better the compliance.
Yeah.
So that's a given. But whether you should be flexible, definitely. You should tailor ERAS to every program. So not all the components should be, like Rajat said, shoved down the patient's throat. But you should ensure a greater than 70 to 80% compliance. Otherwise, your ERAS doesn't work.
So for the benefit of the postgraduates, we would like to go through few scenarios, and I would like to know your expert comments on that. So it's the first case. It was a 68-year-old male with obstructive jaundice for 2 months, who had a weight loss of 8 kg over 3 months. He was a smoker since 40 years with mild COPD, diabetic on OHA for the past 10 years. His BMI is 19, HB of 9.8, albumin 2.8, HbA1c is 8.4, and serum bilirubin of 10. Diagnosed to have a resectable head of pancreas malignancy, and he was planned for Whipple's surgery. Now, the concerns are malnutrition, borderline glycemic control, anemia, frailty, and he is planned for a major oncological resection. So, do we optimize or operate early? So, let us see how Dr. Sohan would like to prehabilitate this patient in a short preoperative period.
Yeah, so like this patient is some 68 years, elderly, male with diabetes, long-standing diabetes, and albumin of 2.8, hemoglobin is also less than 10, HbA1c is 8.4, is high. So like uncontrolled diabetics, low albumin, anemic patients with low BMI. Yeah. So definitely this patient need optimization. I also want to ask surgeons, do they want to drain the or they want to do upfront? Because nowadays many surgeons, they want to do upfront surgery. They do upfront surgery also, that is also fine. But depend on the surgeons what they want. Many times this bilirubin 10, they may operate also. What do you think, sir?
So,
That question, I know that the evidence is, I actually asked Dr. Aparna.
So Dr. Aparna mentioned in the morning she wanted the bilirubin to be less than 3.
3, yes.
Yeah. So
But,
I think
yeah,
she's
so
not going to
like,
take.
Brain was dented.
Yeah.
Many times they drain, but sometimes they offer to operate, but most of the time they drain. So this patient, in our hospital, I will have at least 2-3 weeks or 4 weeks waiting period for the surgery. And then by the time the patient first come to the first OPD, the surgical OPD, if we start the prehabilitation part from that period, even if you don't have any waiting period, you can do a good prehabilitation in this patient. So an anemia correction is needed. You need a good high protein diet in patient because your albumin is 2.8 and 2.8 is just cut off. So there is evidence that any albumin less than 2.8 is having a bad outcome. That is an independent predictor for the postoperative mortality. So 2.8 I will not be very comfortable. So I will go at least the 3 or 3.2 or 3.5 or 4 is better. HbA1c and all this, I will say like we have to optimize the comorbidities also. So that pre-operative part is you have to optimize your comorbidities, you have to do anemia correction, you have to also want to know what is the something ever tolerance or something like any physical ability of this patient because we are not mentioned.
Meds are not there.
Meds are not mentioned. So because this patient is having a weight loss, elderly male. So I also want to build some exercise capacity to this patient. So whatever time, even if I have 1 week time, I will optimize this patient.
Yeah. Just to build on that, in urology, we're never in a hurry. So we have data from meta-analysis available from the UK, which says that you can wait up to 3 months from the time of diagnosis before affecting adverse survival outcomes. So you have that much time to actually work with the patient. So prehabilitation is extremely, extremely critical. Sir has already mentioned, we need to get the HP up, the albumin up. The protocol in urology for cystectomies is neoadjuvant chemotherapy. So post-chemotherapy, obviously it takes a toll. So sarcopenia is an issue, so that needs to be addressed. So we actually have time. Even post-chemo, we have still a window of 6 weeks where we actually really sit and work with the patient.
Yeah.
Yeah. The Aspen guidelines were quite clear as to 2 weeks of delay doesn't cause any problems. More than 4 weeks may increase operability, spread, all that. Especially, for colon cancer, we don't have the luxury for waiting for that long. But what we have realized is that sometimes in the evaluation for the cancer, we waste a lot of time forgetting prehabilitation. So I would feel prehab is not a luxury and a waste of time. It's more a intelligent use of time. So when the patient comes in, you can already start him on some, most surgeons know that this patient is going to go for a resection. So you can start him on prehab then and there. What about giving him IV iron, which is something that we started doing colorectal cancer because blood transfusion, slightly higher risk of oncological recurrence. So IV iron, all this can be done in that 2 to 3 weeks of evaluation before taking that patient for resection.
So whatever time is available, I am sure in an institute you always have a protocol in place and then you have the time and system in place. But for many other people who are going to practice outside, whatever time is available, the day when the patient is referred to the PAC clinic, it is better if your surgeon starts the prehabilitation. Otherwise, I think it is your job to initiate the assessment and start prehabilitation for a better outcome.
So Dr. Brian said the pre-op part should start from the patient's first visit to the surgical OPD,
yes,
not to the PAC, because we already lose around 1-2 week time.
Yes.
So that means that the surgeon's role is very important. We have to take the surgeon in the loop of rehabilitation pathway.
The moment we diagnose, another problem is a lot of patients now are vegetarians.
Okay.
So you need to, enforce that high protein bit. You have to tell them, taking non-veg is not a sin. And if they're still hesitant, please give them whatever you like, Ensure, Cabipro, supplements have to be given.
Yes.
That is something we never used to do because we thought it was not our job. Our job was just diagnosing and operating. But now, we have nurses working with us, specialist nurses working with us. So they ensure that all the patients go on that protocol.
Yeah. Okay. So it's better if your surgeon screens and then initiates and then refers to you. So our work is halved actually. So how much delay is acceptable for nutrition, Dr. Rajat?
So as I said, weeks is perfectly fine. More than 4 weeks, evidence is it's not good to wait more than 4 weeks, especially for colorectal cancer.
In urology, like I said, meta-analysis says from the time of diagnosis, we can actually wait up to 3 months. That's stretching it a bit because the data is coming from NHS, so they don't have early dates for surgery. So that's stretching it a bit, but I think till 6 weeks, we can safely wait.
So do you always have a number? Say if your hemoglobin for this patient is 8.6, you want to attain a particular number, or if there is an increasing trend and if you think the patient is responding, do we go ahead and
the one number we take very seriously is albumin. Okay. Because like Sir mentioned, 2.8 and less is problematic, because then our ERAS protocol goes down the drain, because the patient will definitely end up having a complication because there are multiple anastomosis involved in cystectomy. So that's somewhere we really try and get the albumin up to at least more than 3.5. Otherwise, if it stays below 2.8, then we have to add on total parenteral nutrition. That's something we don't like.
Okay. I wish I had such surgeons
also
in my center also.
One more I want to say, also the albumin and also the albumin globulin ratio. So if there's an AG reversal, that will again be a problematic, because there is just some inflammation going on into the body. This IS already started. So AGR is also important for the surgical outcomes of this thing. So we have to see the total protein, albumin, and the globulin also.
If I may add, ma'am, a normal albumin doesn't mean the patient is nutritionally well.
Yes.
So an albumin in itself, our own shows that 70% of our patients with an albumin of 3.8 have sarcopenia.
Yeah.
So a normal albumin doesn't mean the nutrition there. So even if our patient has a normal albumin, starting him on prehabilitation is not something which is a wrong thing. It should be with nutritional supplements. So all our patients, when they get diagnosed, hopefully will get started on iron and get started on protein, nutrition, all that.
Ma'am, do you generally refer your patients to your psycho-oncology to give them prehabilitation as a part of prehabilitation?
So currently I am not aware that we are doing it, but definitely this is a step forward and we are going to take it up from here.
Okay. So Dr. Aparna, what is the role of preemptive analgesia in oncosurgeries?
So preemptive analgesia, when we are talking about establishing analgesia prior to the surgical incision. And the big thing it does is it takes care of the surgical stress response. Obviously, when you have some sort of analgesia on board before the incision, the other thing is it takes care of the post-operative pain, so patient is more comfortable, their return to functionality is better. And of course, we are talking about, because it's oncology surgery, the chronic pain again is a big problem. So you see lesser frequency of chronic pain in these patients if they have preemptive analgesia. The other point I wanted to say is mainly, so when we are talking about analgesia for oncosurgery, we are talking about multimodal opioid sparing analgesia. So the main point here is you are trying to reduce your opioids as much as possible because of all the associated complications. You have post-op nausea, you have post-op vomiting, you have post-op ileus, and respiratory depression also in case you have overdosed. So, we are talking about those things as well. Again, it allows the patient to have early mobilization, faster return of bowel function, and the main thing is it reduces both the peripheral and the central sensitization. So, it's a good thing to have your analgesia working before the surgeon gives the incision.
So what is your preferred modality, ma'am? I know you mentioned multimodal, but then as a preemptive analgesia, what is your general, is it neuraxial or paracetamol?
Obviously that depends on the surgery,
okay,
the extent of the surgical incision, the patient comorbidities, patient's status, and what drugs to choose obviously will be tailored according to the patient.
Okay. Yeah. Thank you. So what would be the strategy to manage the preoperative? Of course, you have answered that for a favorable outcome. Okay. So how beneficial is carbohydrate loading in these patients, and would you go ahead and give it for a diabetic patient?
Okay, so carbohydrate loading, as I understand, there is probably enough literature to say that it is very helpful as far as non-diabetic patients are concerned. So yes, definitely. But in this patient already with, borderline control, sort of 8.4 HbA1c, there is not enough evidence as yet So it is one area which is, probably open to research, and we need some good quality randomized control trials or, studies to prove that it is of benefit. So again, the main way it helps probably is patients' comfort. Patients are less hungry, they are less thirsty, they are less anxious. Again, it reduces the insulin resistance in the post-op period, translates to lesser degree of hospital stays and better wound healing and less wound complications.
What is the drink that you generally give here in CMC?
So I have been talking to the oncologists across the board.
Okay.
We have different units.
Okay.
So it's not one person doing all the onco work. So like colorectal, I just discussed with Rajat, and they were using for a while, but then again it's out right now. There was a study going on in gynae oncology, so they were using for a while, but then again currently the study is over and they are not using it as of now. I think Dr. Solanki might be able to tell us better.
So like about this question answer, like about in the diabetic, there are some literature says that if your patient has a controlled diabetes, you can even give the carbohydrate loading, and they said it doesn't affect the things with that. But in all non-diabetic patients, your carbohydrate loading is important. This is one of the important parameter of the ERAS pathway, which you have to follow, because it can decrease your insulin resistance and everything. So, and about what drink you say, so earlier, like when there was no commercially available carbohydrate drink available, we used to give epi, not epi fish, but epi. So the epi was, but nowadays there are good drinks available. So we use this Surgicarb available, which is around 450 ml drinks available. Also we have some, like from Neon also we have this Anaesthesia. This is around 390 ml drink is available. So we can use like one of anything available, but if you don't have anything, then you can even use your epi, which is the clear fluid, clear carbohydrate fluid.
So we give somewhere between 300 to 400 ml 2 hours before the surgery. Okay.
So are you following 12 hours before 100 grams and 50 grams in the morning of surgery, 2 hours pre-operatively?
So our this is our very important parameter we follow. So we, like in every department, we have one research nurse like dedicated for the ERAS. Then this is the nurse work to give all these things to the.
Yeah.
So does the fizz in the epi make any difference?
Yeah, so the fish, they say this is something carbonated, and that is affecting the. That's why we will want this non-aerated drink, which is a clear fluid.
Yeah. Okay.
So in urology, we stick to Tropicana, the clear one.
Yeah. So having seen the preoperative ERAS guidelines, what these experts follow, we'll move on to the intraoperative phase. So this is a 61-year-old male, bladder carcinoma, planned for open radical cystectomy with ileal conduit, hypertensive, CKD stage 3, coronary artery disease, stented 2 years back. 2D echo is normal right now with normal ventricular function. He is optimized preoperatively with ASA 2 status. So the concerns here are long duration surgery, major blood loss, hypothermia, and bowel manipulation. So how invasive do we need to be? So can we go for a minimally invasive approach or deemed ERAS friendly? What is the reality?
So the broad answer to this question is yes, because minimally invasive surgery, now we have like 8 RCTs comparing robotic cystectomies to open cystectomy, and all have shown that the short-term benefits are great. Small incisions, so less pain, less analgesic requirement, faster ambulation. The bowel handling is much lesser. The blood loss is significantly lower. Length of stay in our meta-analysis shows that there's a benefit around 0.5 to 1.5 days. I don't know whether that's truly a great benefit in the Indian setting, because in open surgery, you're discharging the patients on day 5. Robotic cystectomy, it's either day 4 or day 5. So these are the so-called benefits. But there's a caveat to this. This comes at a great cost. Your open surgery may be around under 2 lakhs. Your robotic surgery is 5 lakhs. So 3 lakhs more for this. What about the hard outcomes? Cancer-specific survival, overall survival, complication rates, not different. They are pretty much similar, at least in radical cystectomy, unfortunately. Yeah.
Ma'am, the problem with the question is that when you say minimally invasive procedures are deemed ERAS friendly, it automatically in somebody's minds becomes open surgery is ERAS opposite, which is a very, very wrong. It's basically MIS becomes like a seductive myth that if you have done laparoscopic work or robotic work, it's ERAS. Open surgery means NG, catheter, drain, nothing to feed, NPO till 7 days. So I feel that actually open surgery needs ERAS much more than minimally surgery. This multimodal analgesia much more important in open surgery. Open surgery usually ends up in patients. We want to do it faster, shorter, more morbid patients. So they need ERAS much more, and so ERAS is I think ERAS is something that has to happen. MIS is just a tool.
Okay, yeah. So because even in our center, what I have seen is robotic radical cystectomy, you can ambulate the patient the very next day. So that is one advantage, major advantage, even if there is no difference in the day of discharge. But they are able to ambulate, which is one of the main component of ERAS, I think, even if they are more than 85 years old. So the other thing which I wanted to ask here is a CKD patient. So does your anesthetist say anything if you do a long duration robotic surgery in a Trendelenburg position, or do they really accept? Ma'am, what is your take on that?
So obviously now it's onco surgery, it has to be done. So I don't think we can refuse surgery to this patient. Yeah, obviously we do explain the risk. We take high-risk consent and we plan for optimization of the patient and adequate discharge to ICU or HTU or to the ward, depending on how the patient is, how the post-op conditions.
So do you ask them to convert at any point if you see any, no, because we ask with a class. So.
Okay. I think that is the surgeon's
also. Dr. Sohan
this is a very important point, actually.
Yeah.
So actually, that CKD patient doing for a long-standing MIS, so the first thing you have to do it very fast.
Yeah.
Okay.
Yes.
Thank you. Then you cannot keep your pressures very high because I have to have the renal
renal
perfusion
perfusion,
maintained.
exactly.
Okay? If they want, I want the pressures of 15 or 16, 17, then no, boss.
Yes.
You have to keep it 12 or below 12. Yes. That's okay. So and then they have to be fast. Because that MIS has a definite benefit over the open surgery, so we allow
we
that.
have to give the benefit to
yes.
the patient. Yes, okay. So is epidural analgesia still necessary, or multimodal analgesia made it obsolete? Where are we heading, Dr. Sohan?
So I am a strong believer of epidural. So because I know there's a lot of study, they say you can give this block or that block or that block. They study the comparable outcome, but I really don't believe that they really have a comparable pain relief. So
for minimally invasive surgeries too?
So for minimal surgery, epidural is not required. I can say that you can give your IVPCA or some block can work, but for open abdominal surgery with this rooftop incision, or for this Magochi incision for the liver or the midline incision, that definitely need an epidural. I need epidural, and in our hospital we mostly put epidural. If the epidural is contraindicated, if the patient refuses to put for the epidural, then we can go for the other block.
Okay.
So,
ma'am?
So I agree with Dr. Sohan. Like he mentioned, obviously open surgery, epidural works well. Provided you take care of, obviously you have to see some degree of hypotension, you need to have some probable low-dose vasopressor on board. But for minimally invasive, there is enough evidence to say that other blocks and with the preemptive analgesia already in place, probably we can get away without putting an epidural, and it might be an overkill.
Okay. Do you practice intrathecal opioids, ma'am?
Yes, we do.
You do give for all minimally invasive surgeries?
Not for all, but depending on the patient and the surgery.
Okay. I just want to clear from the anesthesiology group, because when I was working abroad, I mean, people are moving away from epidural. It's something sticking out of the back. You know, it is, I mean, even while putting the epidural and even afterwards, it causes a little bit of discomfort to the patient. Okay. And there are now alternatives available, like tap block and all. So surgeons in the US were moving, away from this thing. For example, in RPLND, you'll have a big, long incision. So they'll insist on a tap block. So because you want to ambulate the patient as early as possible, you don't want him to be connected to this thing. And you give other modalities of whatever, IV, no, just Tylenol, paracetamol. So is that, are there studies which are, yeah.
So thinking that like, if you see their data and their patient, they all talk about the opioid sparing and in their patient they get a lot of opioid in the post-op period because their pain relief is not enough. So that's why they put the PCA and everything and so many opioids they give in the post-op period, you don't believe that. Yes. And they still say we are opioid free and something like that.
Opioid-free anesthesia.
They just lied on the data.
Yes. But are there RCTs comparing tab block to this? Because, because in urology, I know all the guys who work with me in cystectomy, I'm dead against opioids. My patients don't receive a single drop of opioids. And they're all out by 5 days. Just epidural, and that opioid-sparing epidural is what I worked with Georgine, one of this thing. And post-op, only Tylenol, paracetamol. No, nothing else. So and it works. So it works. I remember while I was training, I won't mention the departments, patients will be pumped with opioids Q4 hourly, and they'll be lying dead like zombies. I'll be waking up, giving them sternal, chest physiotherapy. I know Rajat knows which department I'm talking about, but that was the practice. I don't know whether that's changed or not. And we've radically moved away from that. And our patients are doing so much more better,
So epidurals now, sorry, can I just, we have improved medications. We have low dose epidural, you have walking epidurals, so it's not a barrier to mobilizing the patient,
So they are not blocking the motor power by the epidural. With the epidural, they move around the hospital.
Yes.
My Whipple's patient, open Whipple's patient move next day with the epidural around the ICU or around the recovery room. Yes. So if you have a good epidural, and they don't need any other drug, just the paracetamol, epidural and PCM, so 1 gram TDS, that's fine.
Yeah. Epidural still stands the gold standard.
No, it is the gold standard. I don't disagree with that. I'm saying epidural works. All our patients are on epidural and paracetamol. It works beautifully. And ERAS, we are able to implement this. I'm saying, is there anything better coming? Where you can get rid of that tube which is sticking out of the patient.
It is a contraindication.
So they are all inferior to epidural, I can say. If you have the contraindication to epidural, yes, we have the choice. But if you want epidural versus then, that's not really comparable, I can say.
Yes, because you need to have a catheter in place that you have to give boluses through that. And it is not very predictable. Regarding the size of the epidural tube, when you sensitize the patient when they come for pre-medication, I don't think they mind that small epidural catheter sticking outside when compared to the drain tubes, I think. Okay.
All are in colorectal, all our open patients have epidurals in place. Yes. We don't give opioid analgesia post-op.
Okay. Can I? Yeah. Please.
I know, I think it's Georgine here, because I actually work with, over the last couple of years, we had a professor from Anaesthesia, a colleague, who I worked with. And first I was dead against opioids. So I'd say, I don't want a single drop of opioid in your epidural also, So I think we reached a compromise where she went down to the lowest possible dose. I don't know the exact dose, but she did go down to the lowest possible dose. And post-op, there was no opioids used at all.
Yes.
Yeah, we use small doses of epidural morphine that helps cut down on the local
anesthetics.
Yeah, so like in GI surgery, we use the 2 mics of fentanyl per ml. But for the thoracic cases, we go up to 5 mics for first 2 days, and then we reduce to 2 mics because this lateral thoracotomy pain is the severe pain, and we don't want to give any other drug. So up to 5 mics only for the thoracic cases for first 2 days.
If I don't mind adding on, I think in the West, they have better opioids than what we have in India. So post-op, they can afford to spare epidural and give opioids which are better. We in India, actually, as of now, sadly, we have only morphine and fentanyl, which will cause the patient to be sedated post-op. But in the West, they have much better NSAIDs, which are selective, and better opioids, which probably will come into the Indian market sooner than later.
And in the West, the irony is they give opioid antagonists, albumopan. Yeah. They give albumopan, which is not available, so expensive. So that's the irony. You're actually giving albumopan also to the patients in the West regularly.
That albumipan, obviously, it's not an over-the-counter drug.
Yes.
It has
Not.
the
It is very expensive,
It's
not
very
available.
expensive, and it's not approved everywhere else, not in Europe. So I think US, North America, probably the only place using it. And I don't. I mean, is it a good way? Like on one hand you're pumping in opioid and then you're giving albumipan.
They don't. This is to actually counter the endogenous opioids.
Okay.
They want to counter even the endogenous opioids. You're not pumping. See, that's the, I don't know, that's not true. In the US, at least in North America, they've totally gone away from opioids. There's no opioids. So that's why they're giving albumipan to counter even the endogenous opioids.
So now we have remifentanil available. So intra-op, probably a good drug to use, but then there's a lot of anti-analgesic effect, like it can,
Rebound hyperalgesia.
So rebound hyperalgesia can be there. The other drug we are talking about is oliceridine, which is under testing still. So as and when it comes, obviously we might have some better agents to help out with the opioid problem.
Yeah, the opioid-free anesthesia, again, there is no clarity between when the patient should be opioid-free, like pre-op, intra-op, and again post-op. Most of these studies, whatever has been published, they say about intraoperative. After discharge, the patient again gets an Ultracet or tramadol tablet, most of the patients, and there is no literature-based or there is no evidence saying opioid-free covers the post-operative phase or not.
Hello.
Basan sir, you wanted to add
pointed
something?
out by the Dr. Sogan, when you have the gold standard in epidural, unless it is contraindicated, we need to think about the other thing. And as pointed out exactly by the anesthetist, more anesthetists, about the epidural morphine. If you give the low dose epidural morphine, where, unlike the subcutaneous or the IV morphine, you will be giving every 4th hourly kind of thing. The 3 milligram morphine is not going to affect your GE motility in any way. It's not going to cause the paralytic ileus. So ultimately you need to balance whether you want to have the patient with pain, which is going to cause more problem, that's going to increase the ileus and it's going to increase the morbidity of the patient and the post-op stay, or you want to have that patient's VAS score less than 3. So whichever thing is good for the patient for that particular thing. If it is epidural, if it is it's not a contraindicated, I feel it's epidural should be the way to continue.
Yeah, so the ultimate goal is the pain relief.
Yes.
How we are doing is different.
Yeah. Should advanced hemodynamic monitoring be used in all cases, or keep it simple or go all out? What about the minimally invasive surgery? That's what I wanted to know.
So this patient, if you ask me, probably, I mean, we are talking of goal-directed fluid therapy. So at the minimum, you are going to put an arterial cannula, and you will be putting in probably a central venous catheter as well, because you're expecting, it's a long surgery, blood loss, patient has got comorbidities, you might have to have some sort of inotrope or vasopressor on board. So, that said and done, if this patient is optimized, so probably I would just put an outline guide with PPV, or, there are other modalities available, obviously, are advanced hemodynamic monitorings with stroke volume variation and flow track, vitiligo and whatever is available. Plenty of monitors on board, but that said and done, depending on the extent of the surgery, patient and patient comorbidities, and how the patient is optimized or unoptimized, we can decide and put our monitors.
So it is personalized to the patient. So
How do you ensure there's no overhydration? Because that's something we are worried about when we're handling bowel, because bowel edema, translates to ileus, translates to increased length of stay. So that's why I also tell my anesthesiologist, please don't give too much fluids. Please don't give too much fluids, at least till I'm done with the DBC.
So the goal-directed fluid therapy, how do you do it? He's going to answer it.
Yeah, so goal directed. So like we have to have one goal. We can have any goal. There's just some dynamic marker, some static marker. So we, in all these cases, we mostly have an arterial line. I'm not talking about the stroke volume variation. I'm not interested in, because if you have very high volume disease, something like very big high pack, I will put. Otherwise, I will not put a stroke volume variation. Arterial line I will put in this case because it's a CKD case and long-standing cases. The patient may be having some hemodynamic fluctuation and all these things. I'm not interested in a central line, because this low dose vasopressors I can give from the peripheral line also. I'm not interested in seeing the CVP also. I even don't put central line in the hepatectomy patient also. We only put if we need a high dose vasopressor, and that if required, we to put intraoperatively. So arterial line and then simple arterial line and the PPV. So that pulse pressure variation on the monitor. Based on that, I will do my hemodynamic monitoring in this case. I'll go direct fluid therapy. In these cases, I will go around 2 to 3 ml per kg per ml per kg body weight of the fluid. The 3 is ideal, 2 is little bit less, but I do 3. But our group is go from 2 to 3. So I am little bit around toward the 3 side. So the 3 is okay. Sometimes, many times the surgeon explain there is a bowel edema, and because if you have edema, then the suture will give away and all these things. So we give, even when your BP, everything is normal, I give little low dose of the vasopressor. This noradrenaline, like just I put some 2 mg in 50 ml and I run around 2 to 3 ml dose, along with, if required, only if required, there is a lot of edema, then I give 1 albumin also. Okay. That is 4% as a colloid. Otherwise, I don't give. So even if your BP is normal, I'm putting some noradrenaline so that to handle the bowel edema, so that the surgeons are also happy with this.
Okay. So, yeah, we are running short of time. What are the major intraoperative decisions that help fasten postoperative recovery?
So I think just sticking to intraoperative decisions, we try and make the incisions, even in open surgery. Earlier we used to go above the umbilicus, now it's all incisions, all short, small, infraumbilical. In this patient, in cystectomy per se, this patient's GFR was, I think, CKD 3. So it can vary from 30 to 50. So lower the GFR, we try and avoid major bowel dissection. Don't go for a neobladder, especially with CKD 3, heart dissection, go for an ileal conduit. Shorter surgery. So surgery has to be quick. Second thing, very important, is blood loss. Earlier, we used to lose easily 1.5 liters, but now with better instrumentation, we have the, Thunderbeat, we have staplers, clips. So use that, make sure there's hardly any blood loss. Make sure the anesthetist doesn't transfuse unnecessarily. That's a thing. That's very, very important. So the other things is tubes. Tubes, unfortunately, in urology, because there are 2 anastomosis, there's a bowel anastomosis, there's a urinary ureteroileal anastomosis, urine leak is a concern. So the tube is not put to enhance recovery or this thing, just to ensure that we diagnose a urine leak early and intervene. So earlier we used to put 2 drains, now it's reduced to 1 drain. We used to do splint all the ureteroileal anastomosis. Now in our department, we've started to go away from splinting also, because splints can be associated with the UTI. Pyelonephritis. So we are going away from splinting, but that can be done in an environment like CMC, where you have monitoring, everything is available. Not all surgeons are comfortable. They love to put splints, stents, etc. And the other thing is bowel handling, bowel washes. When we open the gut, people earlier used to give a lot of bowel wash and all that, and that causes spillage, and translocation of gut bacteria and ileus and all. So we've moved away from bowel washes. So these are some of the things we are doing here in our department.
Okay. So we'll move to case 3. 58-year-old female, no known comorbids, laparoscopic LAR done for rectal carcinoma, shifted to ward with stable vital signs. Post-op day 0 with Foley's catheter on IV fluids, IV opioids and NSAIDs, and ondansetron. Concern is here post-op analgesia, anastomotic leak, mobilization, and length of hospital stay. So is ERAS too enthusiastic about recovery? Early feeding versus anastomotic leak. Are we too quick to feed?
Early feeding does not cause anastomotic leak.
Okay.
Actually, contrary to that, we operated on a lot of radiated patients. The bowel needs the nutrition, and you're actually keeping the nutrition away from the patient. So it's better to feed early. The problem is not the feeding, its problem is our mindset and the patient's mindset that can hopefully be changed.
Okay. So ERAS advocates opioid sparing. Are we compromising patient comfort for protocol adherence?
So opioid sparing is okay. We can give, but the thing is that India is already opioid sparing. Our patients are not getting opioids.
Yeah.
So it is a problem of the US, not India. Yeah. Opioid overdose is the problem of the US. In many medical colleges, you will not get opioid. The strongest opioid you get is on tramadol.
Yeah.
So
we face opioid dearth actually.
Yeah, so that we have to get some opioid to the patient. So opioid sparing, so it's my patient, the opioid sparing means I gave so that induction dose of opioid. So I give some 100, 150 microgram fentanyl to the induction. then I don't give any opioid intraoperatively or postoperatively because my epidural is working well. In no epidural, then the catheters are working well. So an induction dose is required. I think that much dose we can give. And we are not really compromised on the patient pain. Pain is the main thing. If you have pain, give opioids in the post-op period, because ultimately the patient need to be. If you are worried about the opioid-related adverse drug events, that is we give it if you are giving for opioid for a simple cut on the finger, that will be a problem. So we have to give opioid if the patient feels pain, but most of the time we will not require the opioid.
So early removal of drains and quick mobilization, how feasible it is?
I think I touched upon that. Drains, actually we are trying to move away just because of the fact that we have the ureteroileal anastomosis. There's a chance of urine leak, though it's less than 5%. Also, while doing the surgery, there's a lot of urine spillage in the peritoneal cavity that can cause a little bit of a chemical peritonitis and ileus. So that's why we put in a drain. But earlier we used to put 2 drains, one per urethral drain and a pelvic. We moved away from per urethral drain. These drains also come out on day 5 after we check the drain fluid creatinine, because always they'll have some drainage. So that's the protocol. Drain fluid creatinine is checked on day 5, and irrespective of what the volume of drain is, we remove it. So that's one thing we're doing. The other thing is splint versus splintless. So now we're trying to move away from splints or stents. We're trying to move away from that also.
Yeah.
The only thing that drain does is makes the surgeon sleep well the night. Okay. Otherwise, there's no benefit of a drain, especially in colorectal. Does that mean we always don't put a drain? No, ma'am. Sometimes we do end up getting worried and putting a drain. Does the drain have every evidence to show that it has decreased anastomotic leak, picks up anastomotic leak? Absolutely not. So drains don't help other than getting us to sleep better.
So post-operative ileus, are we doing enough to prevent it?
So post-op ileus, obviously from an anesthetist point of view, we have to see the risk factors in the pre-op period as well. We have to recognize that this patient might be at a high risk. And then obviously these are prolonged surgeries. So you need to see multimodal analgesia, opioid sparing like we already discussed, minimally invasive surgical approach if feasible. And
do you give prokinetics for these patients?
So we see the PONV risk, post-op nausea, vomiting risk. There are APFL score you have to use, and decide based on that how you want to go about giving your antiemetics. And if required, albumopan, then obviously not available in India, only available in North America. And methyl naltrexone is the other drug which is used, can be used subcutaneously, but then we don't use it here.
So, Dr. Vijay?
So what we do is we early feeding, get them up and about, mobilize on day 1, irrespective of whether they're minimally invasive or open. The pain relief is usually good, so they get them about. Hopefully we do enough. We tried a bit of sham feeding with chewing gum. Patient adherence was not the greatest, so we're hoping to get back to it and see if that works. Okay. So definitely we're trying to do as much as possible. What we do realize is that sometimes the worry always there, sometimes we do too much. There's a certain failure rate in ERAS, especially will lead to ileus. Some patients will go into ileus post-op, and what we are trying to say is that pick it up early and don't force them down an ERAS pathway when they're actually failing, especially in elderly patients, which sometimes have a slight rate of failure.
Okay. So which component of ERAS is most difficult to apply in Indian scenarios? Anyone of you can? How to audit and improve the scenario?
So one thing is colorectal surgery, the bowel preparation. They want to do it, especially colorectal surgery. Yes, I want to do it. So that is difficult. It will be colorectal surgery. All other surgeries we can convince them not to do it. Okay. About the drains also, sometimes some surgeons I want at least, please allow me to put 2 drains or 3 drains or whatever this. But that is required. That is because if the surgery required, then you have to do this thing. All other things I think we can, but we don't know. The problem is that how many components.
Yeah.
That is you have to do, and audit is required. Your 70% to 80% compliance should be there. So we didn't study in the HIPEC. Even in the HIPEC, we have a 71% compliance to the 30 pathways which we selected for the HIPEC surgery. So it is, if we have more than 70, 75, then it's
The
better. Otherwise,
outcomes.
there is no need to do the ERAS
Do you have
protocol.
any audit in CMC, sir, for that?
I mean, in our department, we have a ERAS checklist. So all the data is collected prospectively.
Okay.
So we've been doing it since 2017 now.
So your
And we're-
compliance
so
is
yeah,
more
compliance,
than 70%?
yeah, more, no, obviously, it's almost 100%.
100%,
Because
okay,
we
that's
have
nice.
established a pathway. So our patients, so the difficulties we faced initially was after a radical cystectomy, olden days, they all used to go to ICU. So no ERAS. ERAS is out of the window. Okay? So after that, once we improved, anesthesia, surgery, everything improved, patients started going to the general ward. But there, the nurse to patient ratio was very poor. So some of the components like early mobilization and all would get affected. So we established a protocol where our patients post-surgery go to a high dependency unit, where the nurse to patient ratio is much better. They are highly skilled, trained nurses who know in the ins and outs of ERAS. So they ensure ERAS is implemented. The registrars will come and go. They are clueless sometimes, but the nurses are on the dot. Okay. They will maintain. They will call and tell me if something is going wrong. So that's one way we've ensured that ERAS is.
So like I'm really impressed by the 100%. I don't know, even the best of the center in the world, they don't have any more than 80% compliance. So I would really love to see that data because I think
they all go through it because of this pathway. They don't have a choice. If they go to the ICU, then obviously there's no. So it's not that each and every component, sir. I'm saying compliance. Compliance is there because they don't have a choice. Yeah. The patient doesn't have a choice.
So
they're going to a unit where the ERAS protocol is put up on the wall. So there's no choice.
Thank you.
So that's 100% compliance.
Yeah. So what truly matters is right patient, right optimization, and balancing oncological urgency with physiological readiness. Consistency is high impact practices. ERAS is not a protocol but a mindset. Thank you for the opportunity and discussion.
It is always pleasant to see surgeons and anesthetists almost agreeing upon something. Thank you everyone for keeping us all enamored and engaged with your discussion. Could I request Dr. Punita to please hand over the mementos?
Mementos to Dr. Rajat. Dr. Sohan. Dr. Nirmal. And Dr. Appanna. I also request Dr. Amit to hand over mementos to Dr. Punita and Dr. Janani.